Hi, I'm Rampal, an attending physician at the Memorial Sloan Kettering Cancer Center. I've been asked to address the question, how do we treat AML that's evolved from MPD? Certainly, this is a very challenging area, and we know historically from retrospective data that patients who evolve from an MPN to AML tend to have a poor prognosis, and really when putting in the context of other AMLs, they tend to have the worst prognosis amongst all AMLs, considering de novo AML and therapy-related AML. We think that this might be due to the genomic profile of post-MPN AML, which is distinct from that of de novo AML. We know that things like p53 mutations occur in almost a third of patients with post-MPN AML, as well as other mutations such as ASXL1 occur quite frequently, where these mutations are not quite so frequent in de novo AML. And certainly we know that even in de novo AML, these types of mutations carry a poor prognosis. So the genetics may help to explain why the prognosis tends to be poor in these patients. The approach to treatment needs to be informed by the genetics, given what we know about the biology of the disease. And certainly the retrospective data seems to suggest that standard induction chemotherapy has a limited impact in these patients. And we would certainly expect that to be the case in patients who have a high predominance of p53 mutations. That being said, if we think about this from the genetic level, there are patients who very well may benefit from standard induction therapy. And those patients really are patients who are planned to undergo an allogeneic stem cell transplant. Data has shown that patients with secondary AML or post-MPN AML who undergo induction but don't have consolidative allogeneic stem cell transplant really have the same outcomes as patients who are treated with less intensive therapies. And therefore, one important consideration in whether or not to treat a patient with intensive therapy is, are we going to transplant that patient? The second consideration is the genomic profile, and we know that patients with p53 mutations or more than 3 to 4 mutations tend to also do worse with more intensive therapy. And those need to be the major considerations when we think about how to treat a patient. Now, lower intensity therapies have been studied, hypomethylating agents principally, but also hypomethylating agents in combinations with ruxolitinib and in combination with venetoclax, which of course has shown a great deal of efficacy in de novo AML. We know that the complete response rate with single agent hypomethylating agent therapy doesn't tend to be that high. In some series, only as high as 8% true CR rate. In combination with ruxolitinib, two studies have looked at this using different response criteria, which is an important point to keep in mind. But really the response rates in those studies, composite response rates, were in the 40% range, which seems to compare favorably, at least with historical data with intensive therapy. And the survival of patients treated with those regimens in the studies that have been published has ranged sort of from the 7 to 9 month range, which again compares favorably with historical data, but of course we need to be abundantly cautious in comparing trial data to historical data. Data with venetoclax is emerging, and recent data has shown that the response rates with an HMA venetoclax-based regimen, at least in purely blast-based patients, roughly reside in the 40% or so response rate. So all of these treatments really, will benefit the minority of patients in terms of procuring a response. Do they seem to be able to prolong patients' life? It's not clear that the data would fully support that notion, although there is at least some suggestion compared to the historical data. Keeping in mind the earlier part of our conversation about genetics, we know that some mutations like IDH1 and 2 mutations are relatively frequent in post-MPN AML, and those occur in about 20 to 25% of cases, and that opens a novel opportunity to treat patients with IDH inhibitors. And in fact, data from two different institutions has demonstrated encouraging results with single agent IDH1 or 2 inhibitors or in combination with other agents. And certainly I think this is something that is warrants further exploration and is being explored in a current trial from the MPN Research Consortium, which is combining ruxolitinib and axitinib, the IDH2 inhibitor. So that trial is currently accruing, and we'll see how that plays out. So really, to summarize, when we think about the approach to treating a patient with post-MPN AML, I think our first question has to be, what is the overall treatment plan? Do we plan for this patient to go into an allogeneic stem cell transplant? And also, what are their genetics? Or is this a patient with a p53 alteration, or is this a patient with an IDH2 mutation? If we think a patient is a transplant candidate and they don't have a p53 mutation, an induction-based regimen is certainly reasonable, followed by allogeneic stem cell transplant consolidation. If the patient is not a candidate for intensive therapy or is not planned for a stem cell transplant, lower intensity therapy is very reasonable. And that could include HMA alone, HMA plus ruxolitinib, HMA plus venetoclax, or an IDH inhibitor if they do have an IDH 1 or 2 mutation. But I think the essential point is that there is clearly an unmet need in this patient population. And wherever possible, these patients should be prioritized to a clinical trial. Thank you so much for your attention.